Well, good morning and close to noon now. So, I'm very privileged to speak here, and I'd like to thank Sangeeta and the Apollo group, for inviting me here. So my objective today is to share with you the Singapore story about where we are today and how we got to where we are. Today, mostly all of our hospitals are at the HIM stage 6, which is totally paperless, right? And they, of course, have to adopt the standards that was talked about by the panel early in the morning, earlier on before this segment. So I'd like to introduce a little about Singapore and IHIS, because I think it actually speaks to why many of the implementations can actually happen in Singapore, because we're much smaller than you are here in India. We're less complex. We are a one government party rule, all right, and which has been in place for the last 50 years. And this year we celebrated 50 years of our own independence, right, as a nation. And that has been very largely, all right, ruled by just one party. So I think that has also facilitated a lot of the things that we do. Right, well, I'm not a politician, but I'm just saying that, you know, one decision at the top is worth 2,000 at the bottom, right? So we're 5.5 million people on a very small piece of land, all right, just about 700 square meters. And that's the composition of our ethnic groups, all right, largely. But if you ask Singapore people, okay, or if you meet any one of us on the streets, right, if you find a Chinese, Malay, Indian, and a Caucasian, okay, people will tend to think, they must be from Singapore, okay? And we speak a certain language, you know, which is like pygmy English, right? Which is what we call Singlish, which is a combination of all sorts of our own local dialects, right? So 40,000 healthcare providers, right, is whom we serve, and these providers are all in public healthcare. So we run public and private, right? But IHIS serves public healthcare today, all right. So in total, we have a total of 11,000 beds. 450,000 hospital admissions in the public healthcare, and the public sector outpatient visits are such, 3.6 million specialist outpatient clinics, and these see, the specialists that was talked about there just now. A&E, which is emergency department, sees about 800,000 visits a year, and polyclinics, which is our primary care for service run by the government, all right, that sees about 4 million visits a year. Okay, so that in a nutshell, Integrated Health Information Systems was conceived in 2008 as a result of the merger of the then IT departments of the public healthcare hospitals. So there were two major IT departments comprising 600 people. So we merged all the IT people together. I think that has got great benefits, because once you merge the people together, the people who facilitate IT, right, and we did not allow, right, other IT or shadow IT on the ground, right, what happened was that we managed to facilitate, all the consolidation of the systems, and that very much helped the acceleration of the adoption of standards. Because, I mean, before, I was hearing the panel before, right, we had a lot of debate about standards, about, which one is better, in the old days, people talk about CPT-4 as well, and SNOMED CT. But ever since then, right, we had got our hands around and said that we were already adopters of ICD-9 CM. We will continue to adopt ICD-9 for regulatory and for submissions to WHO, as well as for our billing and subvention standards for subvention purposes. That means for the claims, all right, that the hospitals make from government. So that remains on ICD-9 CM, and we had since migrated to ICD-10 in just one fell sweep, because it was one organization that did it, okay? So today we are already all on ICD-10 AM, which is the Australian version, because I think that had actually got the localization for countries like Australia and Singapore, which actually shared very much similar practices. And we adopted SNOMED CT for all our labs, for all the diagnoses, treatments, and so on. So for clinical standards, they are predicated on SNOMED CT. Okay, so we have been on that ever since. Right, so just 3 standards, all right. DRG for the huge medical claims, I mean for, at the aggregate level. Then at the granular level, ICD-10 AM for claims, and then we have SNOMED CT for all the rest of our clinical vocabulary and so on. Right, so we are about 1,200 people. We started as 600 people in 2008, and we've doubled the size. But on top of that, right, the users have more than doubled. In 2008, we were serving only 18,000 users. Right now, we have 40,000. Okay, and we've got from 2 clusters. We have got 6 now. Each of the cluster is a regional health system that comprises of the acute hospital, primary care, family medical centers, and in a continued provision of healthcare for the population in the region. Okay, so we've got 6 of these different regions. All right, so that's basically about IHIS. So that's, and we're comprised of IT people as well as some of the healthcare professionals who decided to take on an IT career. So we've got nurses and doctors among us who have made IT their career. So we have a humble beginning. Okay, this is the evolution of our healthcare IT in Singapore. 1980, we started with a master patient index. That was quite key. All right, so we have a key for everybody. All right, every one of us has a NRIC number, which is the National Registration IC number that we are given, all right, at the age of 12, all right, but when we're born, all right, every one of us has a birth certificate number, all right, and that gets converted to a NRIC number with your photo, all right, at the age of 12, okay, when you're kind of going to adulthood. So that NRIC stays with all of us, all right, through life. And for every one of our record, whether it is a government record, your tax record, education record, can be, your working record, right? For we have something called CPF, Central Provident Fund, that has compulsory savings. So for anything that you do, your driver's license, your passport, etc., everything is predicated around your NRIC number. So we use the same number for our medical records as well. So 1980, we actually started the entire registry, all right, for all our patients, but practically just having billing as our mission. Okay, that's 1980. We did not have much of a clinical system. 1990, we started on clinical systems with our health informatics group. And then, we had many standalone systems because every department could make decisions about acquiring systems. So as a result of the very varied systems, we had a interoperability problem, all right, that is 1990. And of course, then the subject about standards came about. Everybody had their own drug codes. Everybody had their own little interoperability standard within the silo, within the hospital. All right, but things could not go across. So that's the 1990s. All right, but from there, right, we started to consolidate, our administration, our ADT, admissions, discharge, transfer. That's actually predicated on the NRIC number. So we started to do a little bit of that, but still we had many instances. And in the year 2000, right, we had a plan to actually implement electronic medical records. So these are the operational clinical records on the ground. So we had 2 sets. One was a bespoke system for the National Health Group, because in that time when Singapore restructured the hospitals, we had only 2 groups. So we had one that was bespoke. The other group bought a system, okay, from iSoft, all right, and it became Eclipsys. And then Eclipsys got taken over by Allscripts. So now there is Allscripts. So we have 2 on the ground, the bespoke and the Allscripts system, okay? So with that, right, then the subject of HIE and, interoperability came about. And that's when we decided that we would have the ICD-9, okay, and the DRG. We did not have SNOMED at all. Right, then comes the year 2010, after IHIS was formed. That's when we formulated and said we needed to have a SNOMED CT. NEHR was rolled out, and NEHR is the repository. Remember, we have 6 clusters, and each one, the EMR system. So we actually aggregate all the EMRs in our NEHR. So the NEHR is our interoperability as well as the consolidated registry, okay, of all our records. So that's our NEHR strategy. And that has got full interoperability. And actually, interoperability was made possible because of the fact that we made it seamless, for the clinicians. They don't bother. But back end, we have actually, I'll show you later. Okay, maybe. Oh yeah, I'll just tell you a little bit here. Okay, back end we have actually got a whole network of interface engines, all right, largely predicated on Cloverleaf, all right, as well as our ESB, our Enterprise Services Bus, which actually, maintain the flow of information across all our systems. That means between the labs, the EMR, to the NEHR, and so on. But this is transparent, all right, to the clinicians, and they only see their screens, all right, that they operate with. But at the background, we facilitate the flow. And by and large, we didn't have to argue so much about the interoperability standards, but because we were one organization facilitating that, right? Now in 2015, right, the emphasis is on smart healthcare. That means the ability for information to be known, to be sensed, rather than to be inputted into the systems, right? For meaningful output of decisions that the clinicians can have and work with. So this is the value, all right, that clinicians always want. They do not want to spend all their time, right, keying into the systems, but what they want is for the systems to tell them or to give them the options as to what to do, right? So this is the whole idea of the CPOE, all right, and the decision support. So our, well, I think everybody knows you go to Singapore, we are a much older generation, right, compared to India, right? In India, we have, your average age is probably about 20-something. Okay, our average age is actually 40 plus. So we are an aging population, second to only Japan. Right, so because of that, right, we have got a master plan which actually talks about access to healthcare, quality, and affordability. All right, especially for aging populations, affordability is a very big factor. Right, so the strategies for that is this. Okay, so for every one of the different clusters that I mentioned, we have an EMR, and the EMR may be shared. We have cases of 2 or 3 clusters sharing the same EMR system, but the common repository is our national EHR. We used to have an EMR Rex, which is an EMR exchange, that exchange information across all the EMR systems, so that if a patient presents himself at one cluster and later goes to another, all right, his record is discoverable, all right, and is known and presented to him, all right. So we used to do that with EMR Rex, which is an exchange, and then we have subsumed the EMR X into the national EHR system. So these are the objectives for every hospital, right? There must be information sensing, or paperless, all right, and the clinical and business must integrate around the NRIC as the patient master index, and we must have advanced clinical decision support for things like allergies, all right, things like any conditions that the clinicians need to know, either doctors or nurses, as well as the care plans. Right, so that's at the hospital level. At the intra-cluster level, which is within the cluster, involving transfer of patients from acute settings to primary care settings, we need to have integrated workflows and one EMR system across and one patient relationship management, or a PRM. The PRM is similar to the CRM, right, of the customer relationship management. So that actually contains the care plan for the patient. Across the clusters, we have one EHR. That means if I go from a SingHealth to a NHG cluster, which are different, I can discover the records via the NEHR, which presents to them, to the clinicians. Right? And if I want details, because at the NEHR we decided that we didn't want to clog it for performance reasons, for any details you can then zoom into the EMR, all right, for details, for things like all the dosages of the medications along the way and so on. So our enterprise architecture guided us towards our solution harmonization, because then we could take a whole system-wide view or national view. We could create an ecosystem, right, and culture for solution reuse, meaning if some cluster wanted to have a system, they would necessarily have to come to IHIS, and IHIS will recommend a previously done system, a previously implemented system for the cluster. Or if not, if we know that many clusters are asking for the same solution, we will actually convene a work group, all right, that comprises all of them. All right, of course, everybody will say that, oh, because we go into a work group, we get slowed down, right? But we always say, do you want to go fast or do you want to go far? If you want to go far, go together. So that's how, we've been nudging everybody along the way, right? So the first thing we did when we formed the IHIS was to architect the roadmap ahead, get the buy-in from everybody, and we integrated the system. It was quite key here because, you know, when we actually put everything together as a result of forming IHIS, right, we could have access to all the systems. Imagine when they actually started a new cluster, they didn't have to poach from another cluster, all right, for people, because the very same people were facilitating that for them, all right. So that helped to evolve even clinical practice because it became more standardized. But one thing that we did, all right, to actually be a more inclusive society, all right, is that we asked everybody, just let us know what your systems are, and we will interface them for you, all right, so that they get into the entire network. And for that, you could continue to use your system, and you could also continue to use others. But we make sure that at the back end, you know, the data is actually collected and consolidated. And that was a very hard exercise, but that was a technical exercise that we made transparent, you know, to the clinicians. So in doing that, slowly by slowly, for the clinical departments that found that their system wasn't as good compared to the others, right, over time, they had discontinued their own system and then, you know, went in favor of the more, you know, functional system that they came to adopt. So that we found was a very important lesson for us. I mean, that strategy of inclusiveness, all right, rather than say that, okay, you know, let's kill this at the outset. We didn't do that. All right, we just included everybody in and let the system speak for themselves. All right, of course, at the back end is a heavy job, all right, to interface and pull all the data together, get the logs and get the right, systems. But it was quite a technical, challenge. Right. So in the end, right, this is what we want: patient-centric records. Right, that wherever you go, right, you should see the same view of the patient. And we're quite happy to note that, you know, for the third goal, tomorrow we're launching the National Patient Portal, where, you know, every patient, every person will have their own record at last and can see their own record as a citizen. And you can see your children's record as well. So as to standards, you know, we did the common data standards, integrate them, and then we intervene at the right channels. Okay. So the EMR journey, I think in the interest of time, I'll just lead you into, you know, the essential elements of the EMR. Okay, this is our architecture. All right, we had the service channels, right, defined for every EMR. This is what every EMR must have. And then we had the transactional apps and the modules, which are things like the labs and all that, you know. And then, of course, we have the enterprise service bus. Or it was easier for us to do this because we were one group already. All right, and we didn't have to fight with other colleagues, you know, to do this. So this was like centrally done, you know, as a consolidated group. So we had an enterprise service bus, and that actually speaks to the EHR and the ESBs of the EHR. We've got different repositories that we agreed upon, and the enterprise reporting for the warehouse. So one of the key elements of our EMR is actually the closed-loop medication management, which I thought, you know, there were a few lessons to learn. Okay, at the outset, we decided that we must have the 5 rights because medication management and safety is actually primary, okay, to treatments. So there's a lot of value, and we decided that we would actually focus on this. And to focus on this, right, it means that we had to invest, okay, in the electronic prescription system, which is part of the EMR. Clinical decision support is also part of the EMR. But the external systems like the robots, okay, for single dose packaging, these we had to sort of integrate together, and we bought them from, we had 2 brands. One was Omnicell, the other one was Swisslog. Omnicell is a US brand, Swisslog is an Italian brand. So they're just different ways of doing to achieve the same thing. All right, and what we had was a nursing admin system using barcodes. And using barcode is very key because it means that you don't have to argue, okay, about all the standards and all that, right? Everything is translated in the barcode in which you just scan, all right, and leave all that data translation to the IT people at the back end. So we barcoded, all right, at every point, all right, so that to ensure that the same or the right dosage, right, the right method, the right route, the right pill or the right medication is given at the right time to the right patient. So every patient wears a a barcode. We've actually now, that there is a program to actually have RFID, replace the barcodes, right? So this is how it works, right? I think many of you will know this. We have both the inpatient and the outpatient CLMM, all right, or the closed-loop management medications, all right, where, it sort of automate everything from prescription. That means from the time the doctor prescribes the drug, right, there is no intervention. Okay, so the pharmacy reviews the screen, all right, and gives its signature, after which it just proceeds, all right, into packaging, all right, of the drug, and then it gets sent into the medication storage, all right, that is for vials, okay, because the, the pharmacist, the robots doesn't handle vials today. So the vials and all that will go to the ward stock, and then the vials together with the pills and the capsules, right, whatever is the individual dose for the patient, will go into the medication trucks or the medication carts, and then they get administered by the nurse. Everything through just scanning and the barcode. Right, so this ensures the 5 rights, right? And for this, right, we were quite fast for us to attain the HIM stage 6, because stage 5 is actually CLMM. Okay, so the lessons learned was that the robot technology, okay, for filling medication and orders and all that, all right, enhances patient safety because there's no intervention. 2D barcode is something that we have now used instead of the 1D barcode, right, and for all the labelings. And then I think other things like unit dose packaging is, if it's not consumed, because the problem is that if you change, all right, the dosage or you change the medications, then you have to return it. So there must be this proper process to return it, and so on. Okay, so I will leave, the slides will be available, so you can take a look at that. All right, next on to the EMR. Part of the major portion of EMR, aside from the medication management, is the clinical documentation. All right, this is where the doctors come in, and they've got to document, right, every encounter with the patient. So to do that, there are 3 main aspects. Organization support. So we had, adoption along the way, but we had to have a deadline that said that, but we must have 100% adoption by a certain date. Okay. So that is very much, I think, the leadership at the top that actually can drive that. So the organization support is very important, the leadership. We had, in every case, right, the chairman or medical board drive the initiative, and definitely the resources. Okay, so the strategy was that we engaged all the clinical chiefs and the administrators such that this became a goal, a KPI. And then we conducted road shows. We set up sandbox, okay, for people, all right, and so that they could test it, and so on. All right, I guess my time is up, but all right. So for clinical adoption, you can read it. They're all on the slides. All right, and basically, I think the key thing that I wanted to mention here is that there must be integrated on a workflow. All right, and these must be consulted upon. All right, before you implement them. All right, and because of that, you also must do, a minimal keying. That means you do not allow your clinicians to actually be encumbered with all that keying in. So all our screens are actually pulled down. Okay, we've gone from cows to tablets so that they can walk around more easily and make their orders more easily as well. All right, so standards and governance is absolute key, as I mentioned, and you must have the right work groups and all that, to actually implement this successfully. Of course, all these points are important as well. Okay, so I think on the slide too, you can see the governance process. We have one that actually allows us to have a common governance process and common, order sets and common practices, okay, across, at least within each of the clusters, so that we have consistency. And because of the commonality, which is IHIS, we enabled every one of these clusters to adopt as much as possible same processes. Of course, there are differences, but I think along the way, I would say that about 80% are common and probably 20% are different. Okay, so that rounds up my presentation. So if you want to have more details, all right, I hope that the slides can provide you, with the notes. Thank you.